Good afternoon, everyone. Thank you for joining us today. This is the Return to School Support Town Hall from Children's Hospital New Orleans, and this is facilitated in partnership with the Louisiana Department of Education. My name is Kimberly Buckingham. I am the administrative lead at Children's Hospital here and of the School Wellness Program, and will be the moderator today. As usual, we'll go ahead and start our conversation with an update on COVID-19 in Louisiana. And then we'll move into a more focused discussion around student behavioral health tips for different types of learning, school support staff guidance, and then additional guidance for students with disabilities. We'll spend the rest of the town hall opening up the air for questions and answers. So if all participants would please enter their questions into the chat box, I, as the moderator, will be able to pitch those questions to our speakers. We're going to continue our town hall series well into September. We'll be offering these every other Tuesday starting September 1st, but we've shifted the time. It no longer will be 1 to 2 p.m. It will be 3 to 4 p.m. instead. Each session is recorded and will be posted to the Louisiana Department of Education's website, as well as the Children's Hospital New Orleans website. So please reference those 2 points to access recordings. Just as a reminder, what kind of guidance and resources we will be referencing throughout our conversation. The Department of Education keeps their most up-to-date school reopening guidelines on their website, and you can find that through this link here. Additionally, there is an email address titled LDOE COVID-19 support at la.gov, where all participants can forward questions and concerns. And then that content is used to update a dynamic FAQ document that the Department of Education also keeps running. The Strong Start reopening office hours are still taking place on Thursdays from 3 to 4 p.m. into the first week of September, and that's a great opportunity to ask operational questions. And the Children's Hospital New Orleans resources are all posted on our website. We'd encourage all participants to look at the school wellness section for that. There's resources for all stakeholders involved. And we still have our hotline for all schools to use. This will be available throughout the school year and even into the spring. That number is 504-837-7760. And schools can use that hotline for access to a virtual visit, high-level guidance pertaining to a single individual in COVID-19, return to school screening, as well as at-home symptom monitoring. So we'll begin with an update on COVID-19 in Louisiana. First, I want to introduce our speakers. The first speaker that we have joining us today is Mr. Ken Bradford from the Department of Education. He's the Assistant Superintendent for College and Career Readiness. Ken, if you're on the line, do you want to take a moment here to have any opening comments?
Yeah, thank you, Kimberly. This is Ken Bradford with the department. We just want to reiterate our appreciation for y'all, Children's Hospital New Orleans, for hosting these. They've been extremely beneficial. We're getting large amounts of people, and we look forward to continuing the partnership and offering these.
Thank you, Ken. We appreciate you making time and the opportunity to partner as well. An additional member from the Department of Education that we have here that is not noted on this slide is Ms. Christy Jo Preston. Ms. Preston is the Executive Director for Diverse Learning at the Department of Education, and she'll be present in our discussion today to answer any operational questions related to acknowledging the guidelines in situations involving students with disabilities. She'll only be able to participate for the first half of the town hall, so if she has to jump off, we'll make sure to send any questions her way that pertain to her area of expertise and make sure you have the answers to those questions. Next, I'll introduce Dr. Leron Finger. He's our Chief Quality Officer here at Children's Hospital New Orleans and oversees our COVID-19 response for the hospital as well as in collaboration with our system. I'll let Dr. Finger take it away with the update.
Thanks, Kimberly, and thank you, Ken. I know this is a big effort, and I know everyone on the call is at different phases of their reopening, whether it's virtual and in person. So thank you all for your ongoing efforts. Just a quick update for where we are in the state. Our total cases now are just at over 139,000, and about 12,000 of those are in kids under the age of 18, which is somewhere in between 8.5% and 9% of the cases. More children have gotten tested in the last 4 to 6 weeks, sort of, than in the previous 4 to 6 weeks. That does contribute somewhat to that increased number, but the percentage has been around 8 to 9% of total positives are kids. Overall in the state, many regions and parishes do have decreasing percent positivity numbers, but there's still about a dozen, 12 to 15 parishes that have sort of slightly increasing or increasing percent positive rates, but it's much lower than it was about 4 to 6 weeks ago, sort of in the beginning of July, when large portions of the state had percent positivity rates of over 10%. That number overall is fewer. That being said, there are pockets where the prevalence of this disease remains higher than like where I am currently in New Orleans and Orleans Parish. So just to be aware of that. Again, the impact on kids hasn't really changed. It's very few children require hospitalization, but a small subset do. As we've rolled this out and some schools across the state have returned to in-person learning, there's some big take-home points. And I think that number one point, stay home if you're sick, that relates not just to parents of students, but also team members. It's a big, big deal. And reiterating that to the entire educator and team members who work in the school, that it's okay to let us know if you're sick. We'd far more want that than to come to school while you're ill and unintentionally expose people to COVID-19 if you're not sure. So that's a big, big deal and probably bears reiterating down to the local levels when you get with all of your team members as well. Wearing a mask, we've had really good feedback across the state about how much parents and school teams are supporting this effort. I think Louisiana is establishing ourselves as a sort of leader in this and have not had a lot of pushback, at least to this point, and Ken correct me if I'm wrong, from individuals or local schools across the state. So I'm really proud of that effort. Socially distancing is a huge thing. We already know and we've seen when there are cases that are reported at a local school level, the number of close contacts is determined by how effectively we've been able to socially distance within that classroom. And when there's 36 kids exposed to a high school student, it has caused school principals to say, oh, I should have done this differently. And that will limit the amount of kids or other folks who need to go out on quarantine as a result of being a close contact. And then that hand hygiene is super important. It really does help. And all of these things, they're not just additive, but they're exponential and multiplicative. So they're all more protective than just doing one at a time. I'm going to get to later on in the talk. I do see some questions about some specific cases, including immunocompromised kids. So we'll get to that later on in the talk. Ken, I didn't know if you wanted to make a comment about how supportive school systems have been across the entire state about the mask wearing, but I've been very impressed with the feedback that I've gotten from the leadership within the Louisiana Department of Education and the school superintendents. I think that's something that we should really, highlight to the folks on the call and to the people, the general public in Louisiana.
Yeah, that's correct, Dr. Finger. And I think I would also emphasize that, school systems did a great job prior to school opening, securing the necessary supplies. Also, I'd like to thank, our partners at GOSEP for ensuring that there was a face covering in place for every employee and student, as well as providing those backup temporary face coverings to the tune of almost 2,000 per school site, so that they'd have them and they'd be there and be readily available. And I'd say, we're also continuing to work with Department of Health. And, as things change, we're going to be providing on Thursday's call, an official update to the wearing of neck gaiters based on some, recent guidance from CDC and some studies from Duke University. So, yes, but, school systems are to be commended for their efforts for ensuring that there are face coverings being worn and then securing those for staff and students as needed.
Thanks, Ken. I'll just address the one question from Abby that's in the chat. You know, this is about gators, and what Ken alluded to is tomorrow afternoon, I'm having a conversation with Dr. Welch, who's the state medical director, and all the regional medical directors for the Office of Public Health, so we can gain some clarity and ensure that all of the regional medical directors are responding to your questions and needs in the same way and give follow-up to that on the next town hall. I think the question about gators is a tough one because although the CDC has not come out saying not to wear them, we're strongly recommending masks, and I anticipate, as opposed to gators, I anticipate after tomorrow's phone call, we'll have a heightened degree of clarity on the neck gator question. Kimberly, do you want me to answer some of these other chats, or you want to move on and come to these all at the end when we have the summary?
I'm keeping track of all of this information. I'm happy to loop back on them once we get through all this information. We might answer some of it in the process. Okay. All right, I think we can then move on to our behavioral health tip section, okay? So our next speaker is Dr. Ruther. Dr. Ruther is a pediatric psychologist here at Children's Hospital New Orleans. She's a part of a larger behavioral health team that is really focused on best practices for managing behavioral health concerns in the pediatric community, and we're really proud to have her on our team. Thank you for making time today, Dr. Ruther.
Sure, I'm happy to be here. So I've been at Children's Hospital New Orleans for a number of years now, and I do work with young kids up to adolescents, and so I just kind of wanted to share some tips as we return to school to kind of protect the mental and behavioral well-being of all of our children in schools. So some tips that were kind of listed out here, and I'm happy to answer questions or talk about anything else. Is just kind of starting with some tips on virtual learning and then some tips on kind of the small group learning. If you're doing virtual learning, really focus a lot on sharing that positive encouragement. Sometimes it can be harder for that to come across over the web, and students need to work extra hard to engage with the virtual learning. So just make sure that they know you're excited to see them, share that excitement with them. And even if they don't do anything great, but even just for signing into the class. Another thing might be to set reasonable expectations for assignments and work that has to be done outside of the actual virtual class time. A lot of families are having to be flexible with work schedules and who's home with the children and who's able to help them sign into different platforms. And also students may be moving around to different settings as far as different family members' houses or things like that. So just kind of being flexible with what's expected of them outside of those times that they're on the computer with you. For the classes themselves, making sure that you're the one that's setting the bar and setting the rules for good manners, how to be nice to others, how to ask questions, and making sure that kids know if they do have a question and they don't want to bring it up in the virtual session where everyone else will hear them, how can they contact you privately, especially if they're having difficulty with something, they may be more hesitant to share that in front of everybody else. So just knowing that that may look a little bit different with the virtual learning than it would in the classroom. And of course, I'm aware that a lot of y'all might have experience with virtual learning already. And so you may have run into some of this. And so maybe sharing with each other too, things that may have been helpful already. And a lot of times for kids who are doing virtual learning, this may be the only time in their week that they are seeing other children. And so if there's a way that they can kind of feel connected with one another and feel connected with a school environment, even though they're not physically present, it can kind of be helpful to include a fun part of the session, even if it's just a quick wave to each other or a quick saying hello to each other for a few minutes at the beginning or at the end of class. That can be really helpful to have them stay engaged and to have them looking forward to signing in for their virtual classes. And then keeping in mind too that different children may have different experiences and different limitations. So they may need some extra time on things if you notice someone falling behind, or if you haven't heard from someone in a while, you know, or people aren't handing in their assignments. You know, there may be other barriers present other than that they don't want to do the work, that it may be a barrier to signing in or a barrier to accessing a computer at a particular time. So just kind of reaching out and maintaining that communication, knowing that that communication is going to take some extra effort when the child isn't physically present. And then for the in-person learning and the small group learning, I think kids are mostly expecting that things will be a little bit different this year than they were in years past. They've heard things about masks. They have probably started wearing masks already in their environments that they're in outside of school. You know, and so I think they're expecting things to be different, but just making sure that at school we're all setting kind of a calm tone, a comfortable tone, but also that we're aware and alert and careful about washing our hands and hygiene. So kind of just making sure that we're setting the tone for kids so that they know what to expect. So if they're going to be in the same room all day, maybe maintaining a visual schedule so that they can feel like things are changing, they can know what's coming next, and kind of feel like they have different parts to their day, even if they're kind of in that one room. Maybe trying to divide the room into different areas, so each different area might have a separate purpose or meaning to what takes place in that space. So maybe having one part of the classroom for more free time and unstructured activities, and then another one for lunch, or kind of moving around different areas of the classroom at different times of the day. Trying to get creative with breaking up the day to making it feel different or feel like we're doing different things at different times. You could try kind of looking out the window for a certain activity, or turning the desks to face a different direction, you know, in the afternoon versus in the morning. Again, just to give that feel that we're doing something different. Setting expectations for how are you going to provide contact-free encouragement, what they can look for from you, because they may not be getting the same high fives that they used to, but you're still going to be showing them how proud you are of their work and what they're doing. So kind of show them, you know, this is what it's like when I smile with my eyes, even though I'm wearing the mask. And this is what it looks like if we give each other a thumbs up. And if you want to hug your friend, you know, we're not going to hug this year, but let's practice doing our elbow touches or waving to each other, kind of setting that example for them, and then having them kind of encouraging them to do that with their friends as well. And also making sure that our expectations for kids are consistent with their developmental level. So there's a lot of things that you can expect a sixth grader to do that you may not be able to expect a kindergartner or a preschooler to do. And so just making sure that we're kind of mindful of, you know, what can we expect a child to do and how much redirection might they need if we see certain things.
Thank you, Dr. Ruther. This is extremely helpful. We've had a couple of questions come through, and if you don't have additional comments, I'd like to ask them of you now, so while you're on the line.
Sure, and I can stay until 2, so.
Oh, fantastic, thank you. That's good to know. So I'll just ask one question and we'll move on. But there was a question that came up that asked if kids that are participating in virtual learning should keep their cameras on during the entire experience, or would you advise them be off? Are they an distraction?
I think that kind of depends on the class. And I think, you know, it can be balanced with, sometimes it can be nice to have a break and really focus on just paying attention to the teacher. And so sometimes I think it can be helpful for Kids Focus to turn off the camera. But of course, you also want that level of accountability there. I think it can probably be a little bit distracting if they're watching other children. So I don't know if there's a setting where maybe they could see just themselves and the teacher could see them to kind of look for cues on if they need help or if they get lost. But I definitely think maybe there's a setting where the kids can see the teacher but not each other for the learning portion, and then everybody can turn on their cameras and see each other at the beginning or at the end, to kind of have that feel of being a class together.
Great. Thank you so much. Well, we're so happy that you're here and we appreciate you making the time.
Of course.
Okay, thanks. Okay, so we'll move on to our next piece, which is just an overview of fundamental guidance, specifically for support staff in the school environment. And we'll let Dr. Finger take over again. Dr. Finger?
Sure, and I think this is probably nothing super new from what you've already heard before, but going over again, all of these are additive. So essentially you can't do just one and think it's gonna fill the gap. And as you maximize sort of how we're gonna mitigate these, all of these add up together to really decrease the transmission of disease locally. So wearing the mask, and I see there's been a couple of questions about this in the chat. One of them is what is the additive power of a face shield, especially when you're working with younger children? First of all, anyone who tells you a definitive answer one way or the other on that, they don't really know. I suspect there might be some in a controlled environment in a lab somewhere, a lot of additive power, but we really don't know if it adds anything, especially for being around people who don't have have symptoms or haven't been documented positive. Most of our experience, which is extremely limited, revolves around decreasing transmission from known positives. So I think if it's something where someone really feels uncomfortable and wants to wear a face shield, I would be supportive of that, but we're nowhere near mandating that by any means. And also, if someone does choose to wear an eye protection in the form of a face shield, it does not mean that they do not have to wear a face mask. That is still needs to be in place. Figuring out sort of the pathways for all the team members and how they're going to be walking around for the support staff is really important, and knowing and reiterating that social distancing when they're on the campus with both other team members and from the students is going to be important. I think it's just figuring out how to operationalize a complex set of moving parts, and some of this is you can plan in advance, but some of it is going to require a lot of leadership, eyes on, certainly for the first several days once operations begin. Symptom monitoring, I can't tell you how many questions we've gotten about this in the last 2 to 4 weeks about when's the best time to do it and how to do it. Again, no, there's not one perfect answer, but I can tell you a way to not do it is to keep 1,000 kids waiting on the sidewalk in the sun when it's going to take an hour to get them through a single gate. So any way that you can sort of keep kids separated and do it in the early part, whether it's before they step onto the campus or as they get out of cars, to in that sort of first homeroom type of period. And again, this is something that might not yield a lot of positive kids who have fevers, but I think it's a process that we can't ignore right now. Question about isolation and quarantining. Isolation is for individuals who have documented COVID-19 positive disease. That's when you stay away as much as from everyone and try and even isolate within your own household for a period of time that's dictated for how long you have symptoms, but not to be less than 10 days. Quarantining means where you stay in your own household that means you were a close contact to someone who had known COVID-19 disease, and you're in quarantine for 2 weeks, meaning that you don't return to a school campus, you don't go out for a 2-week period, and that's regardless of whether or not you test negative or positive for COVID-19. So understanding that is sometimes challenging, especially the fact that sometimes people in quarantine end up being out of the general public for longer than people who test positive for COVID-19. And that's simply just because the incubation period to catch this disease, so to speak, can range anywhere from 2 to 14 days. Think about how you're going to be around your friends and coworkers, and whether or not you need to carpool, or if you can figure out ways to transport that minimizes the sort of being in close contact with each other. Get comfortable with meetings that are done either via this Zoom technology, or where if you need to be in the same room, where you're truly socially distanced by 6 feet and everyone in that room is wearing masks. And even at lunch, and I've talked to Ken and the local school superintendents across the state about this a lot, don't let up when the students aren't around. I think that's a time when people's guard can be a little bit, everyone wants to exhale a little bit. But all the things that we've spoken about, social distancing, mask wearing, etc., apply even when the students aren't around. So if there's a common area for educators or team members to eat lunch or grab a cup of coffee, it doesn't mean you need to be sitting 1 foot away from each other, because that increases the risk of transmission of disease if one of those individuals unknowingly is positive with COVID-19. So I think I've said it before on these calls, we all need to be accountable, not just for ourselves, but for our friends and our coworkers, and feel comfortable saying, I need a little bit more distance, or, hey, I think your mask slipped down off of your nose. Please be comfortable doing that. And again, be flexible and willing to engage with not only your colleagues, but our parents and their students. I'll pause there, Kimberly. It looks like we have several questions that have come up.
Sure. I'll answer a couple questions to come up from my end. Just as a reminder to everyone, these recorded town halls are accessible on the Children's Hospital website, as well as the Department of Education's website. You can find those underneath the Children's Hospital School Wellness piece. And any questions we don't get to today, we'll make sure to forward onward. There was also a question that Ms. Preston was able to post to the chat box regarding inquiries around whether to document mask usage in the IEP for students with disabilities, and there's no requirement to document that. The BESI policy includes a disability impact exception for students with disabilities, and this applies to face coverings. This should be utilized only when absolutely necessary because of the student's disability. And Ms. Preston posted a link to be able to access additional resources for that question. Dr. Finger, getting back to masks, do you anticipate changes in the guidelines around which grade levels are recommended to use those masks, or is it still 3rd grade and above?
You know, it's still 3rd grade and above, although I will tell you, many schools have extended that down to the kindergarten age group and have been met with enthusiasm. I will make sure, and I know Ken's still on, that I bring that up with Dr. Welch tomorrow afternoon and as well. We hadn't specifically talked about it, but we certainly can bring that up for discussion again. I think, and I think we'll have more after that meeting tomorrow afternoon. There is a requirement. I don't know what SWD means, but yes, we do ask that students on buses wear masks. And I don't think there's any hindrance to wearing a vented mask for a student. I see that's a question as well. I think that's fine, but I'm happy to confirm that. I don't think OPH has a feeling about that. It's fine to open the door during the carpool, and I don't think there's any additive benefit from wearing gloves. It might be helpful to reiterate to any team members that are manning the carpool line to ensure hand hygiene and trying to achieve that social distancing there. So as long as you're not doing this all the time, I think it's completely fine. There's a question about COVID testing. We are able to do, there's 2 types of nasal swabs. One is a nose swab where you sort of go in like this. The other is one that's a little bit deeper. It's called a nasopharyngeal swab. Both of those tests are valid, and we'll be able to make decisions on whether or not, and both of those tests we can believe, in answer to the question from Children's Chalet.
We also had a question come up around a decision tree for school nurses and non-medical personnel acting as school nurses.
Sure.
Dr. Finger, do you want to speak to that?
Yeah, we've Dr. Welch and the regional medical directors and us here at Children's Hospital have worked together to try and create that so that it's visually easy to understand. We are reviewing that tomorrow afternoon, but I think we really spent a lot of time trying to make it as clear as possible with what to do. Again, I know it's clear because I've been answering these questions for 4 months, but I think giving you guys and the teams on the ground an easy visual algorithm to follow, we knew was going to be important. We're also on the call tomorrow discussing the best way to get information to flow from schools on the ground and to the Office of Public Health teams in a effective, efficient, and easy manner. We do have the school hotline who's been working with the regional medical director in Region 1 to help facilitate some of that communication. And tomorrow afternoon, we'll know how they want you guys to communicate with them. Similarly, we're talking about I have a question in the Q&A. If a student is out of school awaiting COVID test results, should the sibling be allowed to come to school, or should the sibling also quarantine until the test results are received? There's a lot of discussion about that because right now, there's no 1 degree of separation that they have to remain out. I think the timing of testing will help answer those questions. Right now, I think aside from Region 1, many areas of the state, tests are still taking 5 to 7 days to come back. We're going to talk about tomorrow what to do with siblings of someone who's positive, because that might create a lot of people who are out when they don't need to be. But that's one of the questions that Kimberly and I have for the state medical director team and OPH. They're helping us drive those decisions. We're not the ones making them, but we're the ones helping you guys empower your teams to enforce them.
I have just a handful of questions before maybe we can move on to the conversation around students with disabilities.
Sure.
What about saliva tests for COVID-19?
So they're very early on in validation of those. There's a few places that the FDA has granted an emergency approval for those. I don't know if anyone in Louisiana is using those yet, but certainly that, if and when they become available, could become a game changer. But again, just because they're validated in one location doesn't mean the test capacity exists here in Louisiana at testing facilities or hospital. But I know that at least here within the greater metropolitan area, our team members are on top of not just that, but other test modalities that might help ramp up capacity as well in the fall.
And we're continuing to get questions around the face shield. This is not a replacement for a fabric mask, correct? And are there situations where it would be appropriate to wear the face shield, like for younger kids?
So the CDC and the Office of Public Health have not said that there's any specific situation where it's necessary to wear a face shield. Going back to my previous answer, there's no data that says it has an added protective value when you're in around people who do not have documented COVID-19 disease.
What about masks with vents in them?
They're fine.
They're fine. How thick does a mask need to be?
I don't think I will put a millimeter on it. I think classically many of the gaiters that are utilized are an incredibly thin material. So I think that's one of the reasons why there was concern about gaiters and their effectiveness at truly blocking the intent of the exhaled air from each person.
Okay, and there seems to be some confusion around exposure, i.e. close contact. Is this cumulative 15 minutes or consecutive 15 minutes, and what's the difference?
I think it's a great question, and we've engaged with the Office of Public Health about this a lot. I think they want to be involved in those discussions. I think it's different if you walk past someone in the hallway 15 times versus you have 7 minutes of very close face-to-face contact 3 or 4 times over the day, and that student ends up being positive 2 days later. I think that those are the things that each regional medical director will want to hear from your local school. So I think within a classroom, probably the decision will be to count that cumulative close contact, But if you just walk next to someone 20 times in a day, that's not going to count as cumulative time of exposure. And I recognize that's not something that you can say it's like this every single time, but a lot of this is nebulous because there's not a lot of science about it. I'm only reporting to you how our Office of Public Health leaders across the state are responding. And right now, their bias is to err on the side of caution. And you can't say, well, I was only with that kid for 11 minutes and I did that 5 times over the day. I think it's well within reason to say, well, that probably exceeds the 15 minutes of close contact. There's going to have to be some degree of ownership at the local level from each school, because you're going to be reporting this to either us/OPH. They're not going to have the capacity to talk to every teacher about exactly what happened. You're going to have to be able to get that information from your teachers and local educators and transmit that in a seamless fashion to OPH. So I'm not intentionally being indirect. I'm just answering as a spokesman for what I've heard from OPH thus far. They're definitely going to want to work with you guys, but there might be an element of caution in the beginning if we can't give them some definitive answers.
Okay, we'll go ahead and move on to our students with disabilities conversation, but other questions that are outside of that realm, we'll make sure to circle back on as well.
All right, this is, so going down to talk about sort of students with disabilities, I think, there's a wide range of learning disabilities where kids can be in the in-person learning environment. When LADOE, came out with the guidance, it really did say we were very cautious and aware of this and included as tolerated. I think this is going to have to be sort of a unique case-by-case discussion with level setting and what expectations are for each of these individual students at the beginning of the day or at the beginning of the school year. And to have those discussions on the local level is far more powerful than for something to come down from the state with a mandate. I think engaging with the parents, engaging with the local school leadership and individual teachers to come up with a plan that makes sense for the student and the students and the other students and teacher in the classroom is important. We're well aware that there are kids with sensory disorders or autism who are going to have a really hard time keeping those masks on. So working with them to see what you can do to sort of continue to mitigate exposure and create an environment where there is an element of social distancing is going to be important. I think as the guidelines came out, the wording was to work with the local leadership. And I still believe that is what Ken and the leaders from the Department of Education would like to see. Again, it's very early on. I've heard some good reports of schools really willing to be dialogue with parents of children who do have disabilities, but I'm not sure sort of what the overarching feedback is from the group. We can come back to that and get the comments from LADOE. Next slide, Kimberly. So again, the population of children that we just described is different from children with what I would say is chronic medical conditions. I think there's very few of these that would prohibit a child from wearing a mask. That being said, outside of the population that's mentioned here that's immunocompromised, I think all of these children almost certainly will safely be able to return to school with their friends. For children who have true immunocompromised conditions, I think that needs to be a discussion between the children's family, their care, and their primary care provider or subspecialty care provider, and the school leadership to really determine what's best for that individual child. Again, we're 6 months into this pandemic in North America. We don't have a ton of data. There does seem to be a small subset of kids who truly have immunocompromised conditions who might be at slightly higher risk for COVID-19 related severe illness. But as a whole, a child with mild asthma or allergies is probably not at increased risk for severe disease compared to a child who does not have asthma or mild allergies. So I think that's something that's important to know. It's not going to put them into a different category of of kids. Kimberly, any questions specifically about that have popped up on the chat?
Yes, can you differentiate how the guidelines might change between faculty and students that are living with either disabilities or chronic conditions?
I think for faculty, it's, those faculty need to have a mask on at all time and pay close attention. I can tell you how we've approached it within the healthcare environment, that if someone truly did have concerns about return to work, that they needed to discuss that with their local leadership. Ken, I don't know, or who else is on from Department of Education, if there's a statewide policy for that return to work, but I can tell you within healthcare organizations across the country, there's a lot of concern about that very early on, but that really hasn't panned out where it's been a problem having people return to the line. In those individual situations, if someone does have some anxiety, I think that's a personal and private conversation that needs to happen with the local school leadership.
Yeah, Dr. Finger, this is Ken. I would just add that you are correct in that those are decisions that are made locally. There's not a statewide blanket about returning and not returning. I would say also that we work very closely with you all and the Department of Health to provide those recertifications to return to work if you're either a student or a school system employee, which is sort of that checklist that they can go through, that rubric, to ensure that if they did test positive, that they're ready and able to return. Those were not required certificates to return, but again, they were a resource that was made available to the school systems should they so desire to utilize them.
Thanks, Ken. I'm glad that we're speaking the same language. I see a question about in a specific case, someone with severe autism who could, and with explosive disorder. If Lori, if you want to contact me offline to discuss that, but I don't think it's going to necessitate necessarily more personal protective equipment being worn by the teacher and the para. I don't think that's going to be necessary, but I'm happy to speak with you offline, and you can contact Kimberly and she can set up a direct conversation about that.
Yeah, Dr. Finger, could you maybe elaborate on that? We've had several questions come through around caretakers not being able to socially distance from students that they have to look out for that have various different types of disabilities. Are there any special PPE or extra precautions those caretakers can make?
So yeah, we've gotten a ton of those. My standing line has been not be extra attentive to keeping your mask on and hand hygiene. There's not been a recommendation to wear PPE in the classroom setting in that situation. I will and I've talked about this with Dr. Welch previously, but I will reiterate that the question has come from multiple different folks on this forum and others to reiterate that. I suspect the answer will still be that it's not necessary, but I understand the question and I will bring it to their attention again.
Would you recommend caretakers to wear N95 masks instead of other fabric masks, or will any mask do?
For the purposes of what we're talking about now, any fabric mask will do.
Okay. And what about faculty or children that come from households involving someone that's immunocompromised, like a grandparent or a parent or a cancer survivor? What should those families do?
I think, again, that's slightly different than the child who's immunocompromised. So I think they need to be confident in their own local school's operational policy and what they're doing to mitigate transmission of disease on the school campus. I suspect that those are families who have limited exposure of the children over the last 5 months. And I think trusting that the campus is going to do everything they can to ensure no transmission on the campus, I think they just need to be confident that that's going to be the case and reiterate for their own child the need to abide by all the rules and regulations that each local school has already enacted.
Okay. What about the use of face shields for students with disabilities or sensory disorders?
You mean as opposed to face masks? If they won't tolerate a face mask? Hey, if they won't wear a face mask, but they will wear a face shield, I think that might be a happy medium, knowing that it's not going to be as protective as if it was someone wearing a face mask, but it might be possible to provide some degree of protection if indeed that child was COVID-19 positive. In my experience with these kids, some of those kids have been able to wear that, but many of them have also not tolerated it. I think it's truly a student-specific decision.
Okay. And getting back to chronic care management, what about faculty that have diabetes? Is there anything unique to that condition that can be impacted by COVID-19?
Can you say the question again, Kimberly?
Adult faculty that have diabetes, are there any unique impacts by COVID?
Sure. So I think diabetes is one of the underlying chronic conditions that we've noted. If those adults do get COVID-19, it's a risk factor to get more severe COVID-19. So just like anyone else, they need to abide by the rules and regulations that are on the campus to really minimize their exposure risk. I do see a question or a comment from Anne to all the panelists about the sensory issues. The guidelines are not necessarily children's hospital specific, but I can talk to the team members. I don't think it has to be a mandate that children with sensory issues wear a face shield, but please feel free to incorporate that, and I'll bring it up with Ken offline after this call. Thank you for that comment about wearing the face shield, Anne.
Are there any adjustments that schools should take whenever doing temperature checks or using the isolation room or anything like that when it comes to a student that might be in a wheelchair or have a sensory disorder?
I don't think so. I think, again, with those, I think many of these are non-touch. So I think just working with the student, as I'm sure the teachers and paras have lots of experience with doing that before, to make it a non-threatening and normal part of their routine.
Would you still recommend non-touch thermometers?
I think if those are possible, it makes it much easier sort of to use in between multiple students and adults, for sure.
And does it matter if you take the temperature on the wrist or on the forehead? Is there a difference?
There's many different types. I think we've had great experience with using the forehead. So I think it depends on the type of thermometer.
Do you have any special guidance for students that have trachs? And is it safe for them to attend school?
Yeah, again, so a tracheostomy would fall into the sort of chronic management. I think it is, as long as the local nurse and local school leadership is aware of it, I think it's completely safe for them to, or as safe as it is for all of us to be out in public, but as we follow these guidelines from the Department of Education. So yes, I think as long as they're aware, I don't know what each child with a trach will have a different constellation of medical issues. So I think those are children who you need to have a direct conversation with their caregivers and guardians. We have several children locally in the greater metropolitan area who we've given the green light to return to in-person education.
If there's a student that has an issue with maybe urinating or having an accident around their caretaker, and are there any extra cleaning protocols or anything more rigorous in light of the COVID-19 environment that you would suggest?
No, do what you would normally do for that.
Okay. What about students with muscular dystrophy and that have occasional respiratory issues?
Yeah, so I think they fall into the sort of kids who have chronic medical conditions. And I think that engenders a conversation with their guardian, their care provider, to come up with a decision whether or not it is safe. I think it's going to be student specific depending on the complexity and chronicity of their disease.
Okay. And then getting back to the temperatures, there's more questions that are coming up around this. One specifically says that, is it possible that taking temperature on the forehead can cause nerve damage?
No.
Okay. All right, so moving off of temperatures and some of the disability questions, getting back to the disease itself, can you review scenarios involving direct contact and exposure? There's more questions that come up around that, and I don't think that's as clear as it could be.
Sure. I think, so again, there's not a one size fits all. So you're talking about if Johnny in school gets diagnosed with COVID-19, what counts as a close contact? What counts? All right. So a close contact is someone who's been within 6 feet of the individual for more than 15 minutes in the 2 days prior to symptoms beginning or a positive test. So let's say Johnny comes to school on Monday, he's doing fine. On Tuesday, he doesn't go to school because he has a fever. He gets a test and it's COVID-19 positive. Anyone who was within 6 feet of Johnny for more than 15 minutes on either Sunday or Monday is counted as a close contact. Okay?
Would you inform anyone of a possible close contact, or would you wait until a positive test is received?
So at this point in time, we're waiting for a positive test, but that's something that we're talking about tomorrow. I think the concern that we've had for the past 5 months, if you notify everyone that a test is pending, all of us on the phone call would probably qualify as a close contact right now. So I think there's concern that there's going to be everyone in the state's a close contact. So trying to find a balance with when we notify folks is one of the things on the agenda for discussion right now.
What about teachers that have to rotate through multiple classrooms? How do they avoid being within close contact or spreading any potential disease if they were to contract it?
Well, I think those teachers are under the same operational guidelines as teachers who don't rotate, that if it's, they're trying to make an effort to maintain social distancing, regardless of whether you're staying in a static classroom or if you're rotating between classrooms where you have different sets of students. I think trying to maintain that level of separation is incredibly important.
So if there is a potential exposure and a group of people is informed that they could potentially be exposed, and then after maybe 6 days, they're informed that there was no exposure in the first place and that the person tested negative, can they just go back to their life? They don't have to keep quarantining?
Yeah, and hopefully that is a situation where we're going to be able to avoid. I would hate to quarantine a group of people for an extended period of time where they do not need to be quarantined. So that's a specific example of why we haven't, to this point in time, quarantined folks without having a documented positive COVID-19 test. Does that make sense to the group? I know it's a confusing subject. There is discussion about whether or not we need to be able to push that button before that COVID-19 test has been resulted. I think everyone's concern is that will result in a large number of people being quarantined when they might not necessarily need to be. Again, the regional medical directors from the Office of Public Health will work with the local school and children's hospital team to help convey that information to make a decision.
And my next question is for Dr. Ruther, if she's still available on the line. There was a question that came through about ways to combat pediatric clinical depression if a child that's immunocompromised has to stay home or is forced to stay in virtual learning when the rest of the school is in in-person learning.
Sure. I mean, I think some of the things that I would recommend you do would be things that I would recommend you would do to kind of prevent or combat depression in any case, which would be establish a sense of normalcy, try to incorporate positive, enjoyable activities into the day, maintain some sort of social contact with people, even if it's just virtual and not person-to-person live. And then also, of course, if you do suspect depression, making sure that having to kind of stay in your home doesn't become a barrier to care. So, we do offer virtual care and telehealth services here at Children's Hospital. And I know a lot of other, local areas are able to provide that service. So just making sure that there's not a barrier to accessing care if you do suspect depression, that child is receiving services.
Thank you, Dr. Ruther. Dr. Fingerthurs, and this is also probably a question for Mr. Bradford. There's a question around reporting. Does the school nurse need to report cases to LDH, LDOE, or maybe go through the CHNOLA hotline? What's the route of communication there?
So Kimberly, I'll take that one. I think, again, we are trying to delineate that more effectively in our conversation tomorrow afternoon. I think we want to make it easy for local schools to have sort of a single number. I know that the regional medical directors across the state have already felt a sense of, they want to respond to everyone rapidly, but it can sometimes be a large number of calls. So we want to create a system whereby you have the support you need and you have the information you need in a time-effective and rapid fashion. So again, we will have more after that conversation tomorrow, because we want to be able to deliver something for you guys that can be effectively operationalized.
Okay. All right. We have about 3 minutes.
Yep. I have a couple just follow-ups. I have asked the team to follow up with me on the valve masks. I understand that the CDC has come out saying that they can still transmit that virus or not be completely protective. I'll have a definitive answer on that tomorrow, because much of that is for use in the medical world. I'll have a definitive answer on the use of vented masks for you at our next town hall.
And Dr. Finger, when you mention a meeting tomorrow, that's an internal meeting taking place with you and Dr. Welch, correct? That's not a webinar that our
No,
panelists...
that is a private, that's a meeting for me, Dr. Welch, and the regional medical directors.
Okay. So, yeah.
Kimberly, there are a lot of questions here still about the testing. I wonder if we could bucket these and include answering them in the facts, because I know that we're close to end of time today, and I do want to get back to them.
Absolutely. So we have about 2 minutes left. If there are any other questions, please feel free to get them into the chat box while you can. Otherwise, I'm going to go ahead and try and knock out the rest that we have, unless you have any comments right away, Dr. Finger.
No, and then I'm going to ask Ann McWhorter. Kimberly will circle back with you offline about your specific interventions that you found with children with sensory issues. Thank you so much for volunteering with that.
As far as carpool management, would you recommend faculty that are managing carpool wear gloves and a mask? Should they open doors? Should they take the temperature in the car? How do you envision that going successfully?
Yeah, I think we already addressed that one. We said that they did not need to wear gloves, Kimberly, and
okay.
I think, yeah, each local school can determine how they operationalize that.
Okay. All right, well, we're getting down to the end here. Just as a reminder to everybody, this is recorded. It will be posted on the Children's Hospital website and the Department of Education's website. Any questions we didn't get to will be included in both organizations' FAQ resources, and we'll incorporate that content in our next town hall as well. And Dr. Finger, during our next town hall, perhaps we can go through our decision tree to talk through potential scenarios involving exposure and symptoms and quarantine versus isolation.
And that'll include who the local leadership needs to call. Thank you guys for all your efforts. I know it's a big lift, but you guys are doing phenomenal. I appreciate it.
Thank you, everyone. We're going to end on a quick video that we have that's just an example of some of our resources from a behavioral health perspective. And we would encourage everyone to take a look at what we have available to you. So I'm going to pull that video up now.
With all the social restrictions associated with COVID-19, many families of young children with autism spectrum disorder are experiencing cabin fever with staying at home so much.
Here at the Autism Center at Children's Hospital, we wanted to give parents some tips that they might be able to use during this difficult time. These tips are going to be helpful for kids with autism, but also for young kids in general, and they could use them during other extended periods of time where their schedules are different.
So the first tip is to think about how to create a schedule that fits with all the social restrictions associated with COVID-19. Children with autism often have difficulty adjusting to changes in routine, and it's likely that almost everything in their routine has been changed by all these social restrictions.
So using visuals is often helpful. So you can use like a visual schedule to help explain to the child and show the child what's coming up next. It'll also help the parents and children together with getting used to the new schedule.
Putting your child's toys in bins and rotating your child's access throughout the day can help them stay more engaged with their toys than if they're just available all day.
It may be helpful to add a special time to your schedule. Special time means it's a one-on-one time for the parent and child to do some fun activities together. This helps the child realize that other times the caregiver may be busy, but this time is a one-on-one time that they get to spend with their parents.
Finding outlets for yourself as a caregiver to take care of yourself is important for you to also help your child. Connecting to social support through social media, video chats, phone calls, and finding ways to express any difficult emotions that you're experiencing but not in front of your child is really important for you to also help your child cope with this.
These are extreme times that we're going through, but we can get through this together and along the way build autism acceptance and awareness.
For more tips and resources on the things we talked about, see our blog and other helpful websites that we linked below. From all of us here at the Autism Center at Children's Hospital,
Let's light it up, Blue.